you. All right, welcome back, everyone. If you could take your seats. And if you're listening to this at home or at your office, please come back to your workstation. I hope everyone had a wonderful break and enjoyed some of those delicious snacks, particularly the fruit smoothies that we had here. And if you're at home, I hope you're feeling restored and refreshed likewise. It is now my absolute pleasure to welcome all of these smart people to the stage for our next panel. We're moving into the theme of how do we design for the future, picking up on where we left off with knowledge is power. So we're going to move into a reimagined system of crisis response, designing with community in mind. This panel welcomes thought leaders who are going to lift up and amplify promising practices and ideas from across the nation, as we're 6 months away from the implementation of 988. So Moki, I'm going to turn it over to you, our wonderful moderator, to introduce yourself and the panel.
Thank you. Good afternoon. It is a pleasure to be here. And I have to say, I was pretty much starstruck when Melissa reached out and shared with me the names of the women who'd be on this panel today and asked me to moderate. So it's really a pleasure to be here today. I'm Moki Macias. I'm the Executive Director for the Policing Alternatives and Diversion Initiative, more affectionately known as PAD, based in Atlanta. One aspect of our work is providing a harm reduction response when people call our local City of Atlanta 311 line for mental health concerns or other community concerns. So it's a real pleasure to be here today in order to learn alongside each of you at this critical intersection of this work. So I want to go ahead and introduce our panel before we dive in. And I'm going to start with Keris. Keris Myrick is the co-director of S2I, the Mental Health Strategic Impact Initiative, at the JED Foundation. She's a certified personal medicine coach. She is also a leading mental health advocate and the podcast host for Unapologetically Black Unicorns. She's known for her innovative and inclusive approach to mental health reform and the public disclosure of her personal story. Dr. Talid El-Sabawi is the assistant professor of law at Elon University School of Law and a scholar with the Addiction and Public Policy Initiative at the O'Neill Institute. She is an interdisciplinary scholar with both a PhD in public health and a law degree. Dr. El-Sabawi is also a member of the advisory circle to the North Carolina Urban Survivors Union, a chapter of the Urban Survivors Union, and frequently works alongside persons who use drugs advocating for policy reform. Tansy McNulty is the founder and CEO of 1 Million Madly Motivated Moms, which is a collective of Black women working to end police brutality by increasing accountability in police officer violence and supporting the pipeline of Black talent in the criminal justice professions. And finally, Dr. Margie Balfour is a psychiatrist and a national leader in crisis care, quality improvement, and law enforcement responses to behavioral health emergencies. She is Chief of Quality and Clinical Innovation at Connections Health Solutions and Associate Professor of Psychiatry at the University of Arizona. So if everybody could just welcome our panel. Thank you. So I want to just start with building off of the preceding panel. What we heard from the panelists in this last session was how both racism and the resistance to that racism in the example of the Freedom House has shaped the systems that we have in place today. So where I'd like to start with this group is to ask you each, as a starting question, can you share how people most impacted today are compelling our crisis system to evolve? Keris, I'm going to start with you, and we'll just go.
Oh, okay.
Yeah.
Where are you going to start? So, first of all, I'd like to thank Sozosei and Natsuka for having us here and for the panel. And I think the most hopeful is that, especially as a person with lived experience, given a diagnosis of what's considered a serious mental illness, that many times we're not believed about what's happening to us and the services and supports that we need, especially when we're struggling. And so finally it feels like, okay, people are listening, and we're trying to be more involved in co-production of what some of these systems and services can look like. So that's a hopeful thing for me.
I've been really energized by I guess the young folks who have really pushed local governments and held them accountable when it comes to non-police responses. I've been really energized really by their tenacity and their unwillingness to take no for an answer. So I think that is what gives me most hope in this intersection.
Yep, and I'll add on to that. So just the fact that the community is not necessarily waiting on the systems to catch up. We're making the solutions, we're providing the solutions, and then you can jump on board if you want to, that kind of thing. So I'm most hopeful about us kind of carving our own space.
And I've been in the field of emergency psychiatry for, geez, almost 10 years now. And so I've been wanting to see this kind of change for a long time. And what makes me hopeful is that there's so much convergence from so many different avenues, because there's suicide prevention advocates, the NAMI advocates, now you've got social justice advocates, and so it seems like things are kind of aligning, the stars are aligning for some real change.
Thank you. All right, so Keris, we're gonna dive in a little deeper with you here. So the way that we talk about our communities and the challenges that they face can either sort of broaden our imagination or constrict it, right? Which has profound implications for the way our systems evolve, what we are able to imagine and what we are able to dream of as possible, right? Which I think kind of relates to the last panel, this comment of, we can't just create the expectation that people will fit into the boxes we already have, but we really have to be more thoughtful, right, and more imaginative. So Keris, you've consistently lifted up the power of stories in your systems change work. From your perspective, how does the dominant language relating to mental health and crisis undermine our ability to evolve our current system?
Okay, so the first place I'd like to start, and I think Vic Armstrong covered this in the last panel, is referring to our emergencies as crisis. Somehow that sets it up as something separate than, and we know separate is never equal. So I think that is problematic for us, if we keep talking about crisis and crisis response, we're not understanding some of the issues that can happen with people as mental health emergencies and how to respond to that mental health emergency. Secondarily, I think the term crisis doesn't also capture many of the social determinants of health that can impact one's overall health, which includes our behavioral health. That becomes something, again, that's a separate thing or not even talked about much in the mental health kind of arena. So, when I'm listening to stories or even thinking about my own story, the other thing that I was really struck about was this idea of, you heard me say it in the beginning in sort of my own introduction, is serious mental illness. We use that term SMI, SPMI, as if it in and of itself, it is a diagnosis. It is not. There's no such diagnosis as serious mental illness. It doesn't exist. What does exist is policy that then states use to determine who qualifies for what according to certain diagnoses that can be categorized as, quote unquote, under this serious mental illness. So there was a difference when I was first diagnosed with it was first an eating disorder, then it was OCD, and nobody said all the things I couldn't, wouldn't, or shouldn't do when I was given those diagnoses. Nobody even thought about thinking about, well, don't go to school, or, you're going to be doing this for the rest of your life, or go into the public system. But as soon as I received a diagnosis of schizophrenia, things just totally shifted. And so I think there is something that's inherent in what we understand about people who are given certain diagnoses that then start to lens through everything that we do. So once I was given a diagnosis of schizophrenia, I was told I shouldn't be going to school, I shouldn't be going to work. Oh, by the way, if you do work, maybe you just want to be a bagger at the grocery store. Okay, a bagger at the grocery store, that's cool. Anybody wants to do that? Right on. But that's not what I wanted to do. And so it became, I would say, a diagnosis of doom, if you will. And so that language around sort of my destiny being very limited, then the treatment that I received was also limited to actually help me achieve that limited destiny. Sort of the Pygmalion effect happened. And so I think, when we think of languaging things as quote unquote serious mental illness, it starts to lens everything for everybody who's going to touch any of those systems that support us. So, for example, if I'm thinking of housing, and somebody is unhoused and you're trying to support people in housing who have been deemed as having a quote-unquote serious mental illness, the public starts to frame it in a completely inappropriate way. So I think those are some of the things around sort of understanding the language and how the language drives the policy and how the policy drives the program that really can impact how we're able to be our full selves and be treated as fully human. Lastly, I think the other thing around language and story is understanding no and the power of no. So when people are saying no, what are they saying no to and why are they saying no? A lot of times we want to say, well, that's anosognosia. They don't really have insight. But my question is, what do they have insight to? And how do we become curious about that? How do we ask questions about that? And how do we meet people where they are when they are saying no? As Black people, a lot of times we're saying no to something because we have no other power. There's such power in the word no, that we're exercising our locus of control. We're exercising sort of a piece of empowerment where we don't have it. In the mental health system, sometimes we don't have a lot of power. So how do we understand that? How do we unpack it? And then how do we help meet people where they are in that no to move them to the yes that they are interested in?
Thank you so much. Appreciate that. Talid, we're going to move to you. So you've worked with drug users, as I mentioned, to create narratives that support decriminalization. What are the compelling messages that you can share with us that have helped move policymakers from a punitive response to drug use to something that is more appropriate? And are there lessons about what messages have helped that could be applied to moving away from a punitive response to mental health emergencies?
Sure. So I think to really understand how framing and narratives work generally is important before we talk about specific narratives that are effective. So when you think of the policy-making process, at the heart of all of policy-making is a battle of narratives, right? We use narratives to define what causes a policy problem, who's to be blamed for the problem, and then we also describe the people that are meant to be helped for the policy problem, right? And how we describe the problem, those narratives that we use are very powerful because they limit the types of policy solutions that are then available to address the problem. Sounds very, very theoretical, so let me give you an example, because how we talk about the people who are affected by the problem can change depending on who we are talking about. So I'm going to take you back for a little history lesson. The first opioid crisis or opiate crisis in the United States in the 1800s. All right, so there was a population of Southern women, white women, who had become addicted to morphine, and their addiction, even in the 1800s, was treated as a medical issue. In fact, physicians were blamed for iatrogenically addicting or accidentally addicting these women to morphine. But at the same time, Chinese men were smoking opium. Chinese immigrant men were smoking opium. And the policy response was that these Chinese men are deviants and that's why they're smoking opium. The same for black men who were portrayed in the media, even in the 1800s, in newspapers, as being impervious to bullets and so forth after ingesting cocaine. And so it's not surprising that morphine is still illicit and available for medical use, right? But at that time, the first drug we criminalized was smoking opium, right? Because it was associated with that target population. It was attributed to a deviant behavior, right? So how are we able to move to decriminalize? There's a lot of politics that are associated with bipartisanship and alignment that really pushed decriminalization forward. But even before that, to be honest, it was and I know this isn't going to be popular, so take it for what it's worth, but it was the use of the medicalization narrative that was borrowed from mental health advocates in the National Institute of Mental Health who were able to effectively medicalize mental illness and get health insurance coverage for it. It was then copied by the National Institute for Drug Abuse, who adopted the narrative of addiction as a chronic brain disease. So medicalization, understand, again, take it for what it's worth. We know the medicalization narrative isn't the best, but it took the talk away from deviance into deservingness, right? So that's the key. We need to move away from deviance and towards deservingness. We need to use narratives that humanize people who suffer from or amidst these emergencies or crisis, depending on which it is, right? We need to support people who are in chaotic substance use. We need to meet people where they are at, because we understand that even if they're still using drugs, even if they choose to live on the streets because they want to live on the streets and they consider that their home, they're still deserving of compassion and they're still deserving of help. And it's moving to that acknowledgement of deservingness that's really the key to getting political support for care instead of punitive measures.
Thank you. And Keris, I want to give you an opportunity to respond or make an additional comment.
Oh, my Lord. I mean, if we want to go back to the 1800s, let's go to drapetomania. I mean, we have a really interesting start as African Americans in this country and being enslaved. Dr. Samuel Cartwright, and I said Dr. Samuel Cartwright, MD, had a diagnosis for runaway slaves called drapetomania. And I mean, come on, if you were a slave, you'd run away, wouldn't you? But why is that a mental health diagnosis? But that is exactly the case. And then a few years later, he decided, okay, for enslaved Africans who are, mischievous in such a way that they are getting out of their work, that was rascality, and I can't even pronounce the diagnosis there. It's, Dysesthesia aeothepica or something weird. Doctors in the audience, you can tell me. But anyway, but the response, the treatment for that was whipping and putting the enslaved Africans in hothouses. And so a lot of our policies, for example, involuntary, like LPS kind of reform stuff, it's not LPS, but involuntary kind of treatment, started around the 1800s, just at the same time these kind of diagnoses and understanding of the enslaved African context is happening. And I think those things still continue today. It seems really weird. It seems like, oh, that's funny, like how would they have a runaway slave syndrome? But I think at the same time, if it existed then, what else existed then that created policies that we keep trying to sit upon now, this weird foundation, if you will, and try to change this foundation. So, I guess sort of to sum all of that up, my concern is as we move forward thinking about crisis, how do we understand our past and the narrative of our past and the context in which, the social context in which that narrative happened in order to move forward in such a way that we really don't repeat what's happened in the past, especially for communities of color.
Thank you so much. Tansy, we're going to move to you here. So we know, we heard a profound story from the Hall family this morning. We know that there are profound consequences when mental health emergencies are treated as police issues, right? That is to say, when the focus is on getting compliance and control instead of connecting to care. So Tansy, question for you is, can you share a bit how you got into this work and what you've learned from the other mothers that you work with?
Yeah, sure. So our organization, 1 in 4 we got into this work because of necessity. We had to do something. And I knew in order to do something, the best way and most effective way of doing it is getting with my homegirls, getting with other Black women who felt as passionately about this as I do. So our goal is to end police violence by the year 2038. That's through legislative policy, through helping impacted families, and raising our children with integrity, with an interest in criminal justice and politics. So we gave ourselves literally a generation. We have 20 years to solve this massive issue. So I come from supply chain, so how do you solve this big problem? You break it down to tiny, tiny parts. So what data do we have? What do we know about police violence? Well, we know that anywhere from between 20 to 25% of police violence deaths are those who have mental health emergencies. So how do we make sure that those people just don't call officers? We have to give them an option, because if there is an emergency or they need care, who are they going to call? So we did what mothers do. We got on the phone. We started making phone calls. We let our social media network knows who we're looking for. We're looking for mobile crisis unit trained clinicians. And we started with 35, and we ended up, we're around 150 now that are on our website. And then we started in the month of July, during Minority Mental Health Awareness Month, releasing it publicly, telling people how to call. So don't wait until there's an emergency. Call these administrative lines now. Become familiar with these clinicians who will come out and help you, so that when there is an emergency, you feel more comfortable. Well, with this work, you mentioned what I learned from the mothers I'm working with. I learned that you can do a lot with just a few people, few very, very dedicated people. And no matter how passionate they are, how powerful they are, you have to kind of sometimes remind them of their power. But these Black women are also tired, very tired, especially from the last 18 months. Mm-hmm. So we had to not only create a solution for mental health crises, but we also have to care for our community to make sure we're managing the Black women in our units too. So every 2 weeks we're meeting with them. We're talking about, what do you need? How can we help you? Providing suicide prevention tips. We have mothers who have family members on the spectrum, how to interact with counselors, school counselors, and then how to have the talk with our children. So what I've learned from them is they're powerful, but they're tired, and we have to be our own mental health community for one another. And then we can do a lot with the little people, just a few.
Thank you. Thank you. Margie, I'd like to bring you in here. Although we know that a better crisis system will have drastically less dependence on police, right? We also know that police may still interact with people experiencing mental health emergencies, right? How do you think we can improve those interactions and create more options for when police do respond, while not baking in the assumption that police are necessary?
Mm-hmm. Yeah, and to start, I completely agree with everything that's said here, where, mental health emergency is not a police issue, but there's still 1 in 4 adults have a mental illness. So police are going to interact with people with mental health challenges, just whether it's because they called for a mental health issue, which we're saying we don't want to do, or they go to a call that wasn't easily, readily identified as a mental health related issue, or just they happen upon some kind of scene. So they definitely need those tools. I think, first of all, setting up the system to avoid sending the police at all possible is the most important first step. And it should be a health first response. So here, or out in Tucson, where I'm at, that is funded by the healthcare system. So, I was talking about narrative and how we frame things, talking about how we're gonna, this patchwork of trying to patch together all these different services with whatever money we can scrounge. I hate that. It's a healthcare issue. We don't talk about that. Where are we going to find money for all these heart attack people so we can send an ambulance to them? The healthcare system funds that. Insurance pays for that. There's an infrastructure for that, and we expect and demand that. So it is possible to build a health first system using primarily healthcare funds. But then when police do have to be involved, then they need the tools. They need to have the training. All officers should have at least some basic training. The model that the National Council recommends is everyone to have mental health first aid training. CIT, which I'm sure most people here have heard of crisis intervention training. The research shows that's best if people are volunteering for it versus being voluntold, but there's things that police agencies can do to incentivize that. And then finally, there needs to be, when police are involved, they need a place to bring somebody, and they need to be able to bring them there quickly and get back about their business as quickly as possible. It needs to be easier to access than taking someone to jail. And it needs to be able to take everybody. I think right now, 988 is catalyzing a whole lot of talk about building all this infrastructure, the mobile teams and the crisis centers. And there is, like I said, no standards. So there's a wide variability in what these crisis centers do. You use the term crisis stabilization unit, and that means 50 different things for 50 different states. And we have to be careful that we don't build these centers that take care of the, quote, easy people that we want to take care of. The people that would often get turned away, the people who are in the most severe emergencies, who, because of their challenges or their intoxication or agitated, violent, those people do not need to be sent to an ER where they're going to get restrained on a gurney in a hallway. They do not need to be sent to jail because it's not a crime to have a mental illness. They need to be taken to a facility that can actually handle that because they're in most need of specialty mental health care. So they are absolutely the ones that should not be turned away.
Thank you for that. Tansy, you want to comment?
Yeah, it's correct. We're going to interact with officers. It's going to happen, but we have to make sure that officers are not centered when those calls are made. The person who should be driving the interaction is the one who is trained to interact with that person and assess that person properly. So I think our country, we just have to really change. Mental models are hard to break. We've made officers our catch-all for literally everything. Like the jack of all trades, master of none, those saying, like we've made them do everything. And it's not smart, it's not wise, and it's not working. So we have to just rethink that, make sure that we're centering the person who needs the care and letting that person be led by the person who is trained to talk to them and interact with them. Just a uniform can be a trigger for Black people, for me. I'll even say for me as a Black person. If you come in with a uniform, I'm already like, okay, or 10 and 2, whatever it might be. So we have to make sure that we're centering, we're centering the person who needs the care and letting it be led by the person who's trained to care for them.
Thank you. So to lead, I think this tees you up really well. You helped design a model law for non-police behavioral health response teams. Part of the intent of this law was to ensure strong community oversight of the approach. Can you speak to that a little bit? Why does this matter? And how might you apply those same principles to how we are designing 988?
Sure. So, our behavioral health system, the services that we provide, most of it were not designed or implemented by people with lived experience in those systems. And, at best, perhaps a token individual was involved. There was one person put on an advisory board or somebody with some lived experience at some point designed it. But we don't center the person with lived experience in our design of the system. And the result is that we have systems that are coercive, that are co-opted, and that don't work, right? So are ineffective. Now, I'm not saying that these systems, even when they're well-intentioned systems to begin with, it doesn't mean that they're effective or empowering or humane. And so we really wanted to, when we were designing that model law, we included direct input from interviews that we did with persons with lived experience, people who were actively in chaotic substance use, people who had recently experienced a mental health emergency, people who had been forcibly institutionalized, people who were housing unstable. And we learned things that we wouldn't have learned otherwise, like the importance of not requiring the person amidst a crisis to give their name, because people do not want to have to give their name when there is an emergency response. And so we included that in the law. It was important to them. That data can be collected, but names would not be collected. So really centering people's experiences and their input in the design of 988 is going to be very important. And again, this doesn't mean just including a token person with lived experience on the board. And it also means including people along the spectrum and meeting them where they're at. So including somebody who is still using drugs, right, in the planning process. Because as a good friend of mine says, the heroin of today, it's not like your mama's heroin, okay? Drugs aren't like they were 40 years ago. Things have changed. But not only in including people with lived experience in the design, but also in the implementation, in the oversight of the program is very important. There's different ways that you can accomplish this. We did it through a community advisory board that we had majority members be persons from the community, and we were very specific at what that would look like and encouraged adopters to change the language to reflect the communities that were being served. We also gave that advisory board power. So not only do you need to create oversight, but that oversight board needs power. We gave them power of the purse, which is a very politically, it's, I'm not going to lie, local policymakers don't like that part of the law. Why? Because that means that the community actually has the power to vote up or down on the budget based on the performance measures. We ask that performance measures be designed by the community. So quality looks like what the community thinks quality should look like, not what a researcher like me or others out here think the quality, how it should be defined, right? So I think that the only way we're going to be able to develop a 988 system that doesn't repeat history is by centering the lived experience of the people that are currently experiencing both emergencies and crises, because I think we should respond before it gets to an emergency. Even when it is just a crisis, before it gets to the level of emergency, we should be responding as well. But I do agree with you, by the way, Keris.
Thank you. I'm going to come back to Tansy for a moment. You mentioned that one of the resources that you've created is sharing via your website the examples, the programs that people are currently able to access across the country. I was wondering if you could speak for a moment to what you see as some of the most interesting examples of these community response teams, and if there are values or practices that are consistent across some of these examples that you'd like to lift up.
So yeah, all the resources are on our website, and we have a little tutorial on there to show you how to find your state and find your location, so people can find the services that are near them. But the most interesting, I think the most well run community response teams are those that are by people with lived experiences, people who are Black or pushed to the margins of society. So one that I would like to highlight is Mental Health First out of Sacramento and Oakland. They are doing amazing work. These are community members who are like, we can train our community members to respond, like empower them to show up. So even like we talked about, getting to the problem before it becomes an emergency or a crisis, training people on just how to have a conversation, how to stand when you talk to, I think the last panel talked about how you stand when you talk to someone who's going through an experience like that. They provide this training like for free to volunteers. And I've sat in on their trainings. I have a lot of respect for their work, but it's led by community members. There's some are mental health professionals, some are just activists, I shouldn't say just because we are powerful, but they are activists and advocates. But the underlying theme or overarching theme is they care. And they live in the community that they're serving. So when the community members see them, like, oh, that's so-and-so, I know them. I know that I can call them because this is happening right now. They're training on how to handle substance use concerns as well, de-escalation, domestic violence planning, exit planning. It's just truly, truly amazing work. And these are people who are literally from the community. So I would just challenge everyone, while we're building 988, to look in your backyards before you hire XYZ consultant or whoever. Talk to the people who are in your backyard doing the work. And don't just, give them a seat at the table, like Dr. Lee was saying. Let them drive. They've already been doing it. The community trusts them. Let them drive the action. Let them not just be there as a token, but no, you have the power, like you talked about, the power to make the decisions and to shut things down if they're not working. And then go back and measure. Okay, we've done this for 6 months, what happened? What is the community saying? What did they tell us? Oh, we shouldn't do that anymore? Well, let's just stop that right now.
Thank you. And quick follow-up. So if someone goes on your website and they search for their state and they are, they're aware of a program that isn't yet on there, can they reach out to you to be able to add it?
Please do. Info@1m4.org, and just tell us who it is and what we do. We do follow up with a phone call though, because we don't want to send you from the frying pan to the saucer. Like, we're not going to move you from harm to harm. Like, we need to talk to who these people are and know who's answering these phone calls to make sure, okay, do you care about Black people? Do you care about people? We have to go through a little bit of a vetting, and a mom can determine if you care about her child or not. We can hear it. So yeah, we followed up with a phone call, but please, yes, anybody that's, non-police response. We also, I will share this, we do have co-responders on our website. That is not our preference, because like I said, I feel like police officers are a trigger. They can be, their uniform, their presence can be a trigger. It's not our preference, but they're not enough truly non-police response teams to cover the people in this country. And we're trying to just share as much as we can. But as we grow the non-police response, I'm gonna phase out the other. So I'll be completely honest with that.
Thank you. Thank you. So our last sort of formal question before we move to questions from the audience and our virtual audience as well is specifically about 988 and the role of communities in its design and implementation. And Keris, we're going to come back to you here. What are your recommendations for community voices to be heard in the design and implementation, of this new resource? And do you see strong examples of community involvement around the country?
So I think, just to reiterate, the very importance of involving people who have been impacted by the systems to be part of the co-design or driving the system change, especially around 988. And there is, in some of the legislation, the assurance that there's supposed to be inclusion of people with lived experience. But there does need to be somebody who's checking on that, which I have done, and I am not that person, but where I live, I've done it because that's what I'm supposed to do, right? Meaning you all can do it too, and that is to find out, who's in charge of the planning of the 988 in your either state or for us in California, it's also at the county level, but at the state level, and to find out who exactly is on the stakeholder and planning groups. And so one of the things I double-checked was who is on the planning group of people with lived experience and or peer providers, people with lived experience who provide supportive services. And it became very interesting. I kept being shuffled from one person to the next person. And it's like, okay, one, y'all got to know who it is. And it is as if it should be one person in a state or a county of 10 million people, is LA County. But one of the things that I found out was very interesting is there started to be a co-optation, or I will use the word bastardization really, of the term peer. And suddenly a peer became something that had nothing to do with the person who was the ultimate recipient of what 988 would be delivering. And everybody thought that was okay. So I think, again, that's not a positive example, my bad, but I just kind of need to have, people be aware of things that are out there. But the other thing I would say is positive examples is what we've done through our work at S2I with Fountain House Center for Court Innovation, the Technical Assistance Center, and Hayward Burns Institute, which is a Harm to Health report, which pulled together groups of people with lived experience who had been impacted by the systems, again, there's more than one system, who had had police interactions or other crisis or emergency interactions to help determine what are some of the things that would be more helpful. Like, how do you want this system to look or systems to look? What kind of responses do you want? Especially, we centered the report on lived experience and race equity. Also thinking about, well, where is it that you live? Like, if you're living in New York versus if you're living in Oshkosh somewhere, which is kind of maybe a rural setting somewhere, it may look very different for communities of color and especially rural communities as a whole. So being able to hear from the lived experience to tell us and tell, the field, these are things that would be super helpful for us when we are struggling, was one of the, I think, really, really positive reports. And it doesn't list it out bit by bit by bit, but I love how you can use the harm to health report against any other reports that are out there, like the report that Margie and I did with the group for advancing psychiatry, and maybe even Crisis Now, because those are not centered on lived experience and race equity. So you can take our report and the recommendations from our report and sit it next to other reports in which that was not a centering piece.
Awesome, thank you. And I assume that somebody who has the power of the keys will drop that link in the chat for that report. So thank you for raising it. And Margie, we'll go to you. So, you were involved with Keris in developing this report, which was sort of described as a roadmap to the ideal crisis system. Can you speak to that a bit? How do you expect 988 to change our local crisis systems? And if you could also speak a little bit to data in the role of that design.
Yes, well, 988, one of the most important things it's doing is making communities realize, oh, gee, we got to have something for it to connect to. And so it's creating momentum to actually look at what is there, what does my community have, and is it going to be adequate? Because 6 months, it's like TikTok. We need to get on this. So what the roadmap does is it talks about some of the essential crisis systems, which are, and some of those are in the SAMHSA guidelines and like in Crisis Now, but also goes further to talk about, well, what happens before the crisis? So what kind of services should be in place for early access and prevention, also after the crisis or after the mental health emergency, so that people stay stable in the community. But most importantly, it also talks about what structure and framework do you need to build to actually implement a sustainable system in terms of financing, governance, oversight, and then what standards to look at. How do you measure how well you're doing? So the roadmap is, it's a tool designed to help communities do that. As far as data goes, that's how we know if we're doing a good job. So I think it's really important to have standards for what we measure as outcomes. Right now we've got, like I said, 50 different communities and 50 different ways of doing things, and we need to start to standardize that so that we can identify what best practices are. And more germane to this conversation is what data we look at is that's a seat of power. And so we need to really be thoughtful about how we look, what data are we going to collect, and how do we look to see if there are disparities. For example, we've got, like where I'm at in Tucson, there's all these great programs where the police can divert people out of the justice system and into care. But that's great that they have that latitude, but are they using it equitably? Whether it's unconscious, or not, is there bias in that? When we are designing services, are we equitably getting people the care they need versus, having them in the justice system? So, all of that I think is important to build a system that's sustainable and serve the community that it's designed to.
Thank you for that. Keris, I'm going to give you an opportunity to comment, and then also for Talid and Tansy, if there's anything else you want to add about 988 specifically before we move to the questions.
I mean, I'm really proud that I was able to partner, with Margie and other people on the Ideal Crisis System report, especially as a person with lived experience and as an African American, to have part of my experience and the experience of other people sort of inform the work that psychiatrists are doing. So again, I think being able to see it as a collaboration and being able to move forward in ways that work for all of us. And I really just want to emphasize there do have to be places for people to go, and a lot of times people will leave out things like peer respite. We talk a lot about peer respite, but there aren't that many in the entire country. In California, we have 5 peer respites in the whole state of California. In LA, we have 2 peer respites for, again, 10 million people. That's not enough. And I also think for family support, and nobody ever talks about this, is families can also use a respite. And how do families have respite where they can go get the support they need? So this is sort of in the prevention, pre-crisis space. And lastly, that the biggest determinant of a person being able to be well actually is their therapeutic alliance, or their relationship with the people with whom they're in treatment with. And that's the least amount of time we spend anywhere. So to me, it's very hard to have the 988 discussion. I'm glad we're having it, but it's a very difficult conversation to have, because where we should be talking about, I think, really helping people is further upstream around building those relationships. How do you have a relationship with a doctor in 15 minutes? Mm-hmm. How do you do that? So I just don't think it's realistic for us to then build on something where, again, people are not going to be getting the best evidence-based support, which is having time for that relationship so that you're able to partner in care.
Thank you so much.
I just want to reiterate that 988 offers a lot of opportunity. When we were drafting the model, and I have to give a shout out to Dr. Jennifer Carroll, who is in the audience, who is my collaborator on that. We started writing the law. Some of the feedback we got from communities was, we don't want to call 911 because we don't trust the police. So we want another number to call. And we went, Dr. Carroll did some research and was like, wait a second, if it's an emergency, it has to go through 911. We can't have another number. And so the fact that, 6 months later, 10 months later, 988 became a reality. Now communities do have another number that they can call. So let's take advantage of that, some very small, tiny political victory, and make it work for the best.
Yeah, I'll just say, we have the opportunity with 988 to really do something different. And we just sat in the panel before, which showed, back in 1967, like, we're going through some of the same, we're repeating history. Like, we didn't build the system for the people. We let the people kind of fall into the system. So I want to make sure that the Sozosei Summit of 2042, that they're not going back and looking at, well, back in 2022, they didn't even listen to the community. Like, let's not do that. Let's make sure that we build this correctly, and we let the community lead our decision-making, our efforts, and we truly listen. We're not doing tokenized table sitting and all this stuff. Just let them lead. And hopefully in 2042, we'll be here like, well, that was easy. But yeah, that's all I'll say.
I'd like to add, if I could, just moderator's privilege. From the seat that I am in the work that we're doing in Atlanta, we hear from community members every day who say, I don't want to call 911 because I know it's not a police response. Mm-hmm. And yet it is often people who are calling because they don't know what to do in a situation with somebody that they don't know, mm-hmm. With somebody that they're not sure what they actually need. Mm-hmm. And I wonder if 988 will actually provide the response in those situations. Yeah. And if not, will many calls still end up coming to 911 and elicit a police response? So that's something that I think about often. Mm-hmm. Thank you so much for your insightful commentary. So I'm going to move to a few questions from our virtual audience and then questions to our in-person. We'll start with this one. Regarding the misuse of psychiatric emergency detention, what policy or legal changes should be made to discover, prevent, punish misuse of the authority to emergency detain somebody, or I'm assuming sort of involuntary detention here? Controls are in place to prevent arrest authority for criminal offenses from being used as a tool to oppress. So why don't we have analogous controls for the authority to emergency detain? Is there any research on this kind of thing?
Well, there is research on this kind of thing, and there is bias. People of color are more likely to be involuntary committed than people not of color, similar to the way there's bias in diagnoses and people getting, more likely if they're people of color to get the serious mental illness diagnosis versus others that are considered less serious. And so we do need to do something about it. That's challenging because not only do we have 50 different states, we have a bajillion different counties, and even within one state, the way the county operationalizes its civil commitment law can vary widely. So one of the things that a project that I'm involved with, as well as I know Judge Leifman's out there in the audience, is involved in trying to write a model civil commitment law that is more modern, because most of these laws were written like in the 50s. And so it's a group through the Equitas Project. I'm one of a handful of psychiatrists on it, and it's mostly people who can speak legal, because I can't. But we're trying to write something more modern that does build in some sort of oversight.
Thank you. Anyone else want to comment? All right, Margie covered it. So I don't see another question yet from the, oh, here we are, okay. All right, the question asker says, I completely agree that our system is not equitable, particularly towards people of color. I just wanted to point out that it's also not equitable in terms of where you live. A person experiencing a mental health emergency in rural America often winds up in a situation where the officer responding has not had CIT training, and even when they have, there is nowhere to take the person for treatment. So I know, Keris, you spoke to this a little bit about that sort of rural-urban divide in terms of resources. Anyone, do you want to take this one?
Yeah, I mean, I think that's definitely the case is, again, why it's so important to be involved or figure out how to be involved in the creation of what would happen in your particular area. And I also want to be careful also to point out that being in an urban area doesn't promise you anything either. Just most recently, I got a call from Dan Gillison to help somebody in the LA area. And, you would think that we would have all the resources in the world, but it took over 8 hours to get a response for this African-American young man. At the end of the day, it was the police who ended up responding, even though we did everything in our power to not have that happen. But that's what happened. And there was a convolution also of mental health and substance use, which can also create another kind of which door and who responds. And it should be no wrong door.
Thank you. And Tansy, do you want to share again the website that has the other resources that you've been collecting? The alternate resources?
It's www.1, the number 1, the letter M, and the number 4.org. And so it stands for 1M4, which is 1 million madly motivated moms.
Awesome. Thank you. All right. I'm going to take one more question from the virtual audience and then get ready to raise your hand for a mic or come to the nearest mic stand. So what work is being done, if any, to join with managed care organizations to address the emergency care needs?
I think that some managed care organizations have crisis response units. In my experience, the ones that I have seen tend to be ones that don't respond first, maybe respond a few hours later. This is very local, right? Very much dependent on how the states set up managed care organizations, whether mental health or substance use treatment are carve-outs, how the block grants are set up. So the point is, it is happening. I don't know that we want managed care organizations to respond to emergency care, but that's, I guess, another conversation.
Yeah, the Arizona system, which is being looked at as, nothing's perfect, but it's being looked at as one of the better models, is an exclusively managed Medicaid system that's evolved over the last 20 years. And we have a crisis line that answers, I can speak the data from the southern region the easiest, because that's where I'm at. But 10,000 calls a month, and then they resolve 80% of those on the phone. They then can dispatch one of 16 mobile teams for our county, and they respond within, I think their median response time is like 45 minutes. And then there's crisis centers that like ours that take everybody and then are able to stabilize most people into community-based care. And then there's various step-down things, and that's all done with managed care, but braided funding with the SAMHSA block grants, state crisis funds, and so that way anybody can receive care regardless of payer. Now, that's a wonderful system, but if somebody with Blue Cross Blue Shield calls the crisis line, has a mobile team come see them, comes to my facility, sees me, we prevent the hospitalization, all of that gets paid for by the state budget item for indigent people. So managed Medicaid is starting to, like, most of the work in crisis care in the healthcare world is in the Medicaid system. Mm-hmm. Some of in the earlier panel we heard about pending legislation from the representative in California, and one of the things it does is makes all federally regulated health plans have to pay for crisis care, which is most of the health plans. And actually, managed care, it makes sense to them. Mental health emergency care is one of these things where the clinical incentives and the financial incentives are actually pretty closely aligned if you think about it. Because what I want my patients to not be in jail, not be in the ER, and not be locked up involuntarily in the hospital if they don't need to be. And if you're paying for stuff, you kind of want those same things because it is less expensive to be in outpatient community-based care. So once these models are explained to managed care companies, they actually support them.
So I don't want, I'm not being critical of managed care organizations specifically. I'm just questioning whether, let me be very clear, about whether or not we need to send a clinician all the time in the first place, or could this be, do we have to medicalize it, right? So as soon as we start sending out managed care organizations, we are automatically thinking in clinical terms. You're more likely to have somebody, there are studies that show that when you send out a clinician-led team, you're more likely to have somebody involuntarily committed than when you send out a non-police, non-clinician-led team. So that's, I think, a question we need to ask before we start asking, should managed care facilities, managed care organizations respond?
Mm-hmm. Thank you for lifting it up. All right, I'm going to start over here with you.
Hi, thank you. Laura Evans with Vibrant Emotional Health. Vibrant is the administrator of the National Suicide Prevention Lifeline, through which all contacts to 988 will flow. And so I just want to thank the panel. This has been very insightful. And I want to also thank you, Keris, and acknowledge that as a part of the Vibrant State 988 planning grants, individuals with lived experience were required. And so I guess we are the people who are going to be double checking on that and making sure that everyone is including lived experience in their planning grant coalition. But my question is actually around the data as we think about building out the larger crisis continuum for individuals who will need services outside of that intervention they receive on the phone through the Lifeline network. And so we know that data doesn't always represent all communities, and that there are intersections of communities that need to also be considered as we look at and analyze the data. So to the extent that communities can drive it, it's really helpful because the data may not be there yet. But that may lead to sort of this problem where it's every community does things a little differently. So we don't have that standardization that we so desire. So just wanted to get some thoughts and feedback from the panelists, and everyone feel free to jump in around kind of how to navigate that push and pull as we wait for more data that involves lived experience and communities of color and kind of all the intersections for folks to be represented and kind of what are those best outcomes. So just wanted to get some thoughts of community, data, push and pull. And we know policymakers love data. So again, it's that push and pull struggle.
Say policymakers love stories, and then data is used to support the stories. And it can be anecdotal stories, it can be anecdotal data. So I think that you ask a great question, but I think we define data too much in quantitative terms, and I think the data that would be beneficial here is some qualitative data, so interviewing, focus groups, things that can really get at what we need in ways that don't involve numbers that can't speak. So I think that it's important to include qualitative
Yeah,
I'm just going to
Did
agree
she?
with her.
All right, she got it.
I'm going to agree with her.
I've been talking about data for a while, so if you want me to keep going, I'm happy to keep
Thank
talking
you.
about
And I would totally agree with that, and also add that we, just like we need community members involved in the design of the care, but also involved in determining what data is looked at, because what data you look at drives what you do. So that's a hugely important decision.
So what we measure and how we measure it, these are subjective decisions that we make, and we don't acknowledge it a lot of times. We just assume that quality means X, or, we're measuring abstinence. Well, why are we measuring abstinence, right? Why aren't we measuring, ability to function in society, or ability to work, or ability, so having very community-driven, defined measures is what is going to be most important for 988. What should we measure, right? Instead of just saying, well, this is what we should measure because we want to see how much money we save by people not going to the ED. I'm not saying, we can measure that, sure. It makes policymakers happy, but that doesn't necessarily mean that 988 is doing, justice for our communities.
And please disaggregate the data.
Oh, yeah.
There's so many times I get data that, X has changed over time and it's showing improvement, but I have no idea how it improved for Black and brown people, LGBTQ, 2SI. I have no idea. So I shouldn't have to ask people to disaggregate the data.
They only have one person in your sample that's a
Oh, my
brown
bad.
person.
Oh, my
They don't
bad.
want you to know that. That's
Excuse me. I'm so sorry.
Thank you. All right, we've got just a few more seconds. Do we have one more person here? Oh, Dr. Carroll. Okay, all righty. All yours.
Hello, Michael Champion from Hawaii. I work as a medical director of the state's adult mental health system. This is a wonderful panel, really wonderful insights as we think about how to be innovative in this space. And it's been touched on a little bit earlier. CIT has been mentioned, but I'd like to hear your perspectives about the role of CIT. I heard the good comments about moving away from a co-responder model in another direction. So some thoughts about the movement that has gone through the country with CIT in its future space.
Is that for me?
We want to hear my unpopular
Yeah, we're thinking the same. Go ahead.
No, please.
So is the question, should we lean more towards CIT? Like we just continue to train officers to just continue. Okay.
As folks are advocating moving towards a co-responder or even away from a co-responder model, CIT is designed to train officers to be in this crisis space and operate in it, as kind of first responders. So if we move away from that co-responder model or law enforcement response model, what would you advocate for CIT in its continuation?
And its continue.
In its role.
So we did a research paper that went along with the model law that really did a deep dive and analysis over the effectiveness of CIT training. And it is effective when you're measuring certain things, like how officers feel, whether or not they feel competent in what they're doing. They do better on pre-post measures. There is not evidence that it actually improves outcomes for the individual who is experiencing the mental crisis. So I think until we start to get convincing data that shows us that for Black and brown persons, that for persons who are amidst a crisis, it is actually working, then we need to interrogate that system and figure out why it is not improving outcomes. There's one particularly concerning study where officers in a large metropolitan city that received CIT training actually were more likely to engage in excessive use of force against a person with mental illness. That's concerning, even if it was one large-scale study. And so we need to figure out why is that happening. I'm not saying CIT could not be useful. I'm just saying the way we're operationalizing it as it is does not seem to be producing meaningful outcomes aside from improving the mental health of the officer themselves. It does seem to improve the mental health of the officer.
Thank you. Tansy, did you want to add something?
Yeah, I would just add that I don't see like co-response as a true alternative, right? So ideally for 1 in 4, for how we feel, officers should not be there. It's better for the person we're caring for.
And I'll speak to lived experience of having been on the receiving end of people who have had officers and co-responders who have had the CIT training, and quite frankly, it depended upon the officer, and it shouldn't. It should be the same no matter who shows up. And so that, deterred me from not myself calling, but having other people call or evading. So I think there still needs work to be done, yeah.
And I think communities are often going to co-response as a first step because I think it's the easiest right now.
Politically palatable.
Because the system I described in Tucson's been like that for years, and so our police force actually tried a co-response model and then doesn't really do it anymore because it makes more sense to determine as upstream as possible and get a clinician-only response. And so that's done at the 911 point, or people can call the crisis line directly. And so it doesn't make sense to send an officer and a clinician out to try to decide what this person needs. You should do it as upstream as possible.
So we are unfortunately out of time. I want to first of all thank our panelists. Y'all were awesome. Beautiful guys.
Thank you, the moderator.
I want to thank everybody who participated in this conversation today, and of course to thank the Sozosei Foundation for creating this space. So thanks.
Thank you.
Okay.
Thank you. Thank you.
Well, that was really such a treat, and I'm so grateful to all of you. I've made the executive decision as the executive director that we are going to skip our break in order to move right into our final session of the day. So thank you all very much.